Hello, welcome to my vlog on cholesterol. Really important subject, something that everyone will have heard of and is relevant to everyone. So where should we start? I think I'd like to start with perhaps debunking a bit of a myth and a couple of terms that you'll hear all the time, but I just think are not based in any sort of science fact, and that's good cholesterol and bad cholesterol. These terms are completely meaningless because it's the very same cholesterol, and what people are getting confused with is a bit of history and a bit about some of the terminology that we use. So let me try and explain. So every cell in a human will make cholesterol, but some cells are net exporters, particularly the liver cells. So the liver will make an enormous amount or enormous percentage of the body's total cholesterol, and it gets taken around the body in packaged up in a variety of molecules. Now, this is the same cholesterol, whether it's good in inverted commas or bad. And typically those terms are used to describe, and you might have heard of these, LDL cholesterol or HDL cholesterol. And in fact, both of those terms are actually incorrect as well, scientifically speaking. So what do I mean by this? Well, cholesterol is not soluble in water or blood, and it therefore needs to be packaged up in particular molecules to enable it to be transported around the body. And these are in much the same way as oil floating on water, for example. And so each cholesterol molecule is packaged up with a coating, something called an apolipoprotein. And there are two components to this: a protein component and a fat component. And broadly speaking, there are two families of apolipoprotein. There's apolipoprotein B and apolipoprotein A. Now, LDL cholesterol is packaged up in apolipoprotein B, and we use the term an atherogenic particle. Atherogenic just means will form fatty plaque within arterial walls. So this is causally linked with atherosclerosis, or furring up of the heart arteries, brain arteries, heart attacks and strokes. So the higher the levels of ApoB, the higher the chance of a heart attack or a stroke or peripheral vascular disease. Now, the problem is that ApoB does not just have LDL cholesterol in it. It will also have other atherogenic particles, such, for example, as VLDLs, or very low density lipoproteins. And yet they are not measured when you have a routine blood test for a cholesterol profile. Now, high density lipoproteins, or HDL cholesterol, are packaged up in ApoA particles, and there's a difference. But broadly speaking, ApoB particles will take cholesterol and deposit it places, and of course, for example, the heart arteries where one doesn't want it, and ApoA will do the reverse. But the actual cholesterol contained within those particles is exactly the same. And furthermore, it will get passed between ApoB and ApoB molecules. So how you can't have a good cholesterol particle that suddenly becomes bad when it switches between an HDL and an LDL. That just makes no sense. And so high and low density lipoproteins, all that corresponds to is how dense the molecules are when they're spun down. And because HDLs have a higher proportion of protein to fat, they're of higher density. That's all it refers to. So the next thing I'd like to talk about in that regard is how does a plaque develop. So a fatty plaque is a build-up of cholesterol and other lipid within an arterial wall. Now, this process takes many decades to happen, and in fact, even from teenage years, at autopsy studies, fatty streaks have been found within the heart artery walls of people that have died. And so this is a very long-standing a process that takes a very long time to occur. And these LDL particles, they will typically get caught up in what we call the endothelium, the inner lining of the artery wall. And there a process of what's called oxidization happens, and over time this initially forms a fatty streak within the heart artery, or let's focus on the heart artery wall, and then over time that will build up and up. Over even more time it will get what we call calcified, and so you'll have calcium build up within the wall of that, and that will become more of a harder plaque. We must remember also that the lining of the arterial wall, the endothelium, is affected by other factors. So for example, smoking will damage your endothelium through toxic effects, and high blood pressure will damage the endothelium because of the mechanical the shear forces on the arterial wall. And so both of these damages to the underlying vessel wall are then compounded when you have excess ApoB particles and cholesterol deposits within those heart artery walls. Now, traditional cholesterol testing, in fact, when I turned 40, I went to my GP and said, "Oh, can I have my cholesterol checked, please?" And you will typically get a few different blood tests done. LDL cholesterol, which isn't actually a measure of your LDL cholesterol, because you can't measure it directly in that way. I think that's probably beyond the subject of this blog. HDL cholesterol, triglycerides, and your total cholesterol. And often people like to talk of the ratio of total to HDL cholesterol, but also, again, I think that is largely meaningless. What we really want to know is what is the concentration, or what is the number of atherogenic particles within the bloodstream. So what's the number of bad actors that are likely to cause furring up of the heart arteries over time? And those tests are available, but they're just not routinely available. And so if one were to have an expanded panel of blood testing, you would look for your ApoB levels, and so that will not just measure your LDL cholesterol, but also VLDL and a number of other atherogenic particles, but also your something called Lp(a), so lipoprotein and small a. Now, Lp(a) is another molecule that is highly atherogenic, so very bad for heart arteries and brain arteries and so on. It's largely genetic, and so if I see a patient who has a family history of problems with heart attacks or strokes in young family members, I would often think that maybe this is a problem with Lp(a), and it's something that we should look to check. And then something else called plaque, which is an enzyme which can be measured and gives us another view of what someone's overall atherosclerotic risk is. And then armed with those values, we can then work out what to do next. And specifically, I'm talking about treatment. I've got a whole other talk on treatment on the platform, so check it out.